My name is Leslie Onion. I'm a scientist working as part of the Chemical Safety and Health team at WHO headquarters, and I'll be moderating today's session. I'd like to begin the webinar by reiterating the very strong cooperation between the WHO and the Conference of the Parties and the Secretariat of the Minamata Convention. This is underpinned by the convention text itself and by several World Health Assembly resolutions, including one on the public health impacts of exposure to mercury and mercury compounds. As part of that resolution, WHO is committed to working with ministries of health on a number of key issues and ensuring as far as possible that public health issues associated with the convention are identified in Minamata initial assessments and national implementation plans. On dental amalgam, an additional resolution of the World Health Organization from 2021 also recognizes the importance of the Minamata Convention and its efforts to call for a phase down of the use of mercury dental amalgam. This this Health Assembly resolution gives WHO a very strong mandate to develop additional technical guidance on environmentally friendly and less invasive dentistry to support countries in their implementation of the convention, including supporting preventive dentistry programs and taking into account the domestic circumstances and relevant international guidance. So today, we're especially pleased to welcome you to the afternoon side event entitled Country Progress, a Way Towards Phasing Down in the Use of Dental Amalgam. And thank you again to the Minamata Convention Secretariat for the opportunity. Today's side event aims to present the progress and challenges in phasing down the use of dental amalgam, to share the evidence-based information on the management of dental caries with mercury-free products and with minimal interventions, and to discuss the multisectoral leadership and collaboration to support countries' efforts, particularly those with limited resources and a high prevalence of dental caries. We'll have two presentations this afternoon, followed by some opportunity for you to raise your questions. The first speaker is Dr. Benoit Varenne, who is leading WHO's work on the global oral health agenda as the dental officer in the non-communicable disease department of WHO. The second speaker will be Dr. Edward Lowe, who is the chair and professor of dental public health, preventive dentistry, and minimal intervention dentistry. He has a particular focus on tooth decay, and Dr. Edward is working with Dr. Tammy Duangthip, who also joins us this afternoon as a senior clinical practitioner in cariology at the University of Hong Kong. And Tammy is a fellow of the Royal College of Dental Surgeons of Thailand and a member of the Royal Australasian College of Dental Surgeons. We've already heard from Isaku that we'd like to encourage you to use the Q&A box to ask your questions, and then we'll try to address them as far as we can during the discussion session of this afternoon's program. So having said that, I'd like you to welcome Dr. Benoit for his presentation. Benoit, you have the floor.
Thank you, Leslie, and good morning, good afternoon, and good evening to all. I should share my screen. And I hope that you can see it.
Yes,
Yes,
we
that's
can.
perfect. Yeah.
Okay. Good. So yes, really delighted to present the key findings of the informal global consultation that WHO conducted in 2021. So as the title of the report suggests, the objective of the consultation were first to understand the level of the implementation in countries of the 9 measures stated in the Minamata Convention, to gather knowledge of the use of mercury-free alternatives to dental amalgam in countries, and also to identify additional measures being implemented to phase down the use of dental amalgam. You can also see below in the slide that we cover a number of main topics in the questionnaire that are, of course, aligned with the 9 measures of the convention. Of course, today, due to the time constraint, it will be not possible to go and to present all the results and the analysis of the consultation. We'll give you only a snapshot of the key findings that aims to inform the discussion in preparation of the COP4. So the consultation, including participants from 80 countries and territories, close to half of all countries in each WHO regions were represented in the consultation, with the exception of WHO Eastern Mediterranean region in yellow color. For those of you who are not familiar with WHO regions, you have this world map, in the background of the slide. So most of the countries who participated, were signatories or parties to the convention, and countries were represented in most of the cases by a chief dental officer. What we call a chief dental officer is usually leading the work on oral health at national level and for the Ministry of Health. So first important result to keep in mind, a large majority of countries, means 84% of countries, were reported to still use amalgam in 2021. So according to our results, the use of dental amalgam was most common in low-income countries and least common in high-income countries. But just important to mention that still 80% of WHO European region were still using dental amalgam also in 2021. It seems that it's in the region of Americas that we have the lowest use of dental amalgam. To understand the stage of the phase down in dental amalgam in different countries, we ask also to the participant, where would you place your country regarding phasing down the use of dental amalgam? So as you can see, overall, 73% of countries were in process of phasing down the use of dental amalgam. It's in orange color in your slide. The remaining countries were divided between those that had no plan to phase down use of dental amalgam. It's in blue. This means up to 40% in low-income countries, and those that already completed it's in gray in the graph. So as you can see on the right side of the slide, country stage of phase down was markedly different by region and country's income status. As an example, 1/3 of countries in the African region declared that they had no plan to phase down use of dental amalgam. In contrast, 23% of countries in the European region and 21% in the Americas declared that they have completely phased out use of dental amalgam. We also ask our participants if they are, we also ask the participants if there are any additional measure or initiative currently being implemented or already implemented in their countries. So only 35% of countries were reported to be implemented additional measures. So the slides show you some example of additional measures reported by the participant and organized by key components. Some countries mentioned, for example, stakeholders engagement, other reported limitation in the use of dental amalgam or incentives to promote alternative to amalgam. Finally, some countries also mentioned measures regarding improvement of dental amalgam waste management as an example. Some others developed national guidelines regarding again, some mandatory in the use of dental amalgam separators in all dental facilities. We have also asked to the participants if there are any specific challenges on barriers reported by categories of actors such as patients, oral healthcare provider, or policymakers in their countries. So, for example, insufficient knowledge and awareness or better insurance coverage for dental amalgam were reported for patients. Interestingly, for oral health care providers, the main challenges of reducing the use of dental amalgam were linked to certain well-known quality of the product, such as durability. So familiarity with the product and the clinical technique associated was also reported. We know that it requires time to change long and well-established practices in every sector of activity. Lastly, participants reported a lack of national phasing down plan or strategy, the long process to develop statutory instrument, or lobbying by some influential group as example of constraint or barrier to phasing down the use of dental amalgam for policymakers. We also try to understand, if there are any regulation to restrict the use of elemental bulk mercury for dental care. This is blue in the slide. To restrict also dental amalgam to its encapsulated form, it's in orange, or with regards to dental supply chain management in the countries, the gray color. So you can see the right side of the slide that differences by country's income status followed again a clear gradient. High income countries are the highest frequency of regulation in all categories. Countries in the EU, European Union were the most likely to have regulation restricting elementary mercury for dental care in blue color, or restricting dental amalgam to its encapsulated form, 64% in orange. Now, a question related to mercury hazardous waste management. We asked participants if dental amalgam separators are installed in all dental facility in blue, in some dental facility in orange, or in no dental facility in gray in their country. So you can see that 36% of countries were reported to have dental amalgam separators installed in all dental facility, while 19 were reported to have them installed only in some public or private facility, and 36 of remaining countries were reported to have no separators installed in facility. Again, response varied greatly by region and country income status, and differences by country income status follow a clear gradient. This is on the right side of the slide. A last result to share from our consultation. So for both dental services and crematoria, we asked participants if they know about the best environmental practices established in their country to reduce and monitor emission and releases of dental amalgam waste into air, land, soil, and water. So to help them, we provided a few examples, such as proper handling and disposal of dental amalgam waste, conducting periodic inspection of dental processes, or adding mercury removal techniques in crematoria for individuals with dental amalgam restoration. You can see that 44% of countries declared to have the best environmental practices established in dental services. It's blue color, while only 18% of countries reported they have the best environmental practices established in crematoria. It's in orange in the side. Important to note is that 54% of participants have no ideas if the country may have the best environmental practices established in crematoria. So now I would like to emphasize key findings of the consultation. The first one, that is related to most of the question or indicators, is the strong and consistent gradient related to country income status, with overall a relatively high level of implementation in high income countries and progressively lower levels from low middle income countries to low income countries. So despite the persistence of important challenges regarding, for example, the regulation and restriction of the use of certain form of dental amalgam, barriers mentioned also by some participants, or about the affordability of dental amalgam separators in some extent, and particularly if we compare the data with the previous consultation we made 3 years ago, the countries covered by the survey are progressively phasing down the use of dental amalgam in implementing the convention measures. We can also mention a number of promising signs of progress, like more and more insurance policies and programs cover costs of mercury-free alternative, or the implementation of new education program and better waste management, particularly in dental school settings. Finally, and it's my last slide, that will focus on the set of action that could definitely support the efforts of countries and therefore accelerate the implementation of the phasing down. I would like to mention the urgent need to reinforce multisectoral leadership and collaboration, particularly between the ministries of health, education, and environment. The crucial importance of increasing the affordability of existing cost-effective and simple-to-use mercury-free alternative. And Professor Edward will give you additional information on that later. And the promotion of universal health coverage could be certainly very helpful in achieving this goal. International and national public health research agenda on cost-effective intervention on oral health should be also supported. The establishment of a clear timeline to achieve the phase-down measure that include a global monitoring framework could also guide countries to monitor and measure progress. Finally, the provision of technical and financial support mechanism to particularly focusing on low-income countries affected by the huge burden of dental disease must be another priority to discuss. I will stop there, and in any case, you could have access to the full report and analysis of this consultation using the link as part of information document posted by the Secretary of Minamata Convention. Thank you very much. Over to you, Leslie.
Thank you very much, Dr. Benoit. It was certainly interesting to get that further update on the progress and challenges that countries are facing. So we'd like to move to the next presentation. And in the next presentation, Dr. Edward and Dr. Tammy will present about mercury-free alternatives that are in use. And this is based on a new WHO briefing note series on the prevention and treatment of dental caries with mercury-free products. And this briefing note will be available before the conference of the parties. So we're hoping this afternoon that they'll give us a little bit of the flavor of what's contained in this new briefing note. So over to you, Dr. Edward.
You are muted, Edward.
We're not seeing your slides at the moment. We were seeing them before, but they're not yet on the screen. Perhaps, Ben, whilst we're waiting for the slides, could I ask you about the universal health coverage agenda? I know that you're working on that in your department. Do you see this as providing any additional boost to the efforts to phase down the use of mercury in dental amalgam?
Yes. Now, can you see my slides now?
Yes, we can, Dr. Edward. Just wait 2 minutes. We'll, Bernard, would you like to answer that question now?
Yes, sure. I hope you can hear me. Yes, it's true that universal health coverage is really the top priority in WHO agenda, it's well for those who are not maybe familiar. So it means that all individuals and communities would have access to essential quality of services that respond to the need and that they can use, without suffering financial hardship. So it's definitely a great strategy, that again WHO is supporting to all countries to ensure that for oral health, for example, that most of the essential oral health care, including, of course, dental caries prevention and treatment, could be covered by a government financial scheme or sometimes also private insurance. So we hope that the number of countries that are implementing such universal health coverage, could increase in the next years.
That's a good movement to keep our eyes on and to hope it brings further progress. Thank you for that. So, Dr. Edward, we're now looking forward to you giving us a flavour of what's in this new WHO briefing note. Over to you.
Okay, thank you. Okay, sorry for the technical hiccup. Okay. So, good day, everyone. Today, I'll talk about ways to reduce the use of mercury through the prevention and treatment of dental caries with mercury-free products and minimal intervention. Mercury is used in dentistry in the placement of amalgam filling in the treatment of decayed teeth. Amalgam is an alloy of mercury with other metals, mainly sulfur. The two clinical photos in this slide shows a decayed molar tooth treated with an amalgam filling. In the following presentation, I will introduce the effective ways to reduce the use of amalgam dental filling. Firstly, through the prevention of dental caries by using fluoride toothpaste, fluoride varnish, and glass aluminum cement dental sealant. Then I will introduce some effective alternative treatments of decayed teeth, including silver diamond fluoride caries arrest treatment, and glass aluminum cement and composite resin dental restorations. Of course, the best way to reduce the use of amalgam filling is to keep our teeth healthy by preventing dental caries. If there is no decayed cavity, there will be no need for filling. And the most cost-effective method is the use of fluoride. Different fluoride compounds can be put into toothpaste for oral self-care. People just need to place an appropriate amount of toothpaste on the toothbrush and brush all their tooth surfaces on a daily basis. This method is safe and simple to use, and it is suitable for self-care in all settings and populations. We can expect to reduce dental caries by 25% through the adaptation of this method. Another way to use fluoride in dental caries prevention is to apply fluoride varnish on teeth. Fluoride varnish is a thick liquid that can be painted on with a tiny brush on tooth surfaces. After application, the fluoride varnish will set quickly and adhere onto the tooth and release fluoride continuously. Fluoride varnish is safe and simple to apply by professionals, including dentists and trained health and care workers. It can prevent development of new caries, as well as to arrest, that is, to stop the progression of early caries lesions. We can expect by applying fluoride varnish on teeth 2 to 4 times a year, the amount of caries reduction will be by around 40%. Besides the use of fluoride agents, we can also use glass ornament cement dental sealant to prevent dental caries. Glass ornament cement, GIC, is produced by mixing a mild acetic acid liquid with a powder containing fluoride, aluminum oxide, and silicate. It can be placed on the occlusal or the biting surface of premolars and molars to seal up the caries susceptible surfaces. It is safe and easy to apply with hand instruments. So we can also expect to prevent new caries and to stop early caries in treated tooth surfaces by 70%. Now I'm going to talk about alternative treatment of dental caries. In treating decayed tooth, we can choose not to use amalgam filling and adopt alternatives such as non-restorative treatment and adhesive tooth color mercury-free filling materials. In non-restorative treatment, we can use silver diamine fluoride, SDF, to arrest active caries. The photos in this slide show the materials and instruments that are needed for placing SDF, the procedures and the clinical outcome. SDF solution is a colorless aqueous liquid containing high concentration of silver and fluoride ions. The solution is applied with a microbrush onto the decayed tooth surface, and the dental caries will become arrested after some time, in a few weeks or months. Results of many clinical studies conducted around the world show that with repeated applications of SDF, usually 1 or 2 times a year, around 80% of the treated active caries lesion in both the primary teeth of children or the permanent teeth in adults will become arrested. They will become hard and remain symptomless. Application of SDF solution by professionals is safe, quick, and simple. It is a painless, non-invasive procedure for dental caries. And it can also prevent the development of new caries. Restoring the successfully treated cavity may not be necessary, so there's no need for amalgam filling. If we want to restore a dental cavity, instead of using amalgam as the dental filling material, we can choose to use glass ornament cement, which is the material mentioned earlier in my talk. GIC can be used in minimal intervention for dental caries, in which a minimal amount of tooth tissue is removed, such as in a traumatic restorative treatment. It can be applied easily by dental professionals with hand instruments only, without access to powered dental equipment. So this restorative treatment can be carried out in both dental clinics and in community settings, such as in school. The survival rate of GIC restorations placed in permanent teeth is high. We can expect it to be around 80% after 5 years. Another point I would like to mention is that GIC is particularly good for restoring decayed cavities in the tooth roots of adults, which is a common dental disease in the aging populations worldwide. Another alternative dental filling material we can use is composite resin, which is a mixture of resin, fillers such as silica, and other organic and inorganic compounds. It has good physical properties such as high strength and wear resistant, and is tooth colored. It can adhere to tooth surfaces through chemical etching and bonding. Composite resin filling can be placed using minimal intervention and is a good alternative to amalgam filling. The three clinical photos in this slide shows how a minimal intervention is used with a composite resin to treat the small decay in the two upper premolars. The placement of composite resin restorations involve a series of carefully administered steps and good moisture control. So some training for the dentists and dental operators is needed, but this is not too difficult. I would like to end my presentation here. Thanks for the presentation, and happy to answer to your questions and queries. Thank you.
Thank you very much for that, Dr. Edward. Does your associate, Dr. Tammy, wish to add anything to the presentation, or should we move straight into the Q&A?
Please go straight to the Q&A.
Okay, thank you very much. Perhaps I can start things off by asking Dr. Edward a question. Thank you very much for that very easy to understand set of options that there are for the treatment of dental caries. You mentioned a number of different treatments and filling methods. Do you have any information about use of those approaches, particularly in low resource settings?
Some of the methods actually can be used in any settings, including the low resource areas. So, for example, the use of fluoride doesn't need any specific requirements. And also, the use of the SDF in caries arrest treatment also doesn't require much support. The ones that will is more difficult to implement is the use of the composite resin restorations, which will require a more sophisticated dental equipment. But in terms of the technical difficulties, it is not too different from placing an amalgam filling.
That's very interesting. And so, do you also have any evidence about any randomly controlled studies that show these preventive programs reduce the use of dental amalgam, particularly those preventive programs you spoke about?
The preventive methods that I've talked about, there are many studies conducted worldwide already to show the effectiveness in preventing tooth decay. And if there's no tooth decay, there's no need for filling. And so that's why there will be a lot of contribution to the reduction in the use of mercury or amalgam in dentistry.
Thank you for that. Dr. Tammy, as a practitioner, what changes do you think we need to see in policy environments to facilitate the use of these alternatives?
So I would say that the government or guideline have to be changed. So for example, like dental amalgam waste, the national guideline, for example, like specific to the dental amalgam waste, or applying for the mandatory waste certificate, or using dental amalgam separator. So these are some the environmental guidelines that have to be implemented or to be reinforced.
And how do you see what do you see as a critical thing to change the understanding of and the skill mix that we need to make these changes versus the experts such as yourself and a general health practitioner, particularly in a low-income country? How do we make that change of the skills and understanding?
In fact, Professor Edward Lowe mentioned about the alternative. So these are alternative, for example, like the composite resin and glass ionomer cement, and also the silver diamine fluoride. For silver diamine fluoride, so it's basically it can be applied by so-called well-mixed personnel. So that means dental nurses, dental hygienists, that because the method is simple. So I think this one, the use of alternative should not have any problems. For example, another alternative is glass ionomer cement, which can be adopted in the so-called remote area or no electricity use. So I think this type of alternative is also available or also can be conducted by the oral health mix personnel or even like general healthcare workers.
Okay, I have one question to Benoit, and I'm looking in the participants list to see if anyone wishes to ask a question. So please put your hand up if you do. But Dr. Benoit, what support to countries or regions is available to countries or regions for phasing down, given that this large availability of alternatives, which we've heard about? What support do you think is available or can be mobilized?
Thank you. Thank for the question. Unfortunately, so far, the alternative that Professor Edward mentioned in his presentation are not fully accessible and affordable in some countries, and it's you know, it's part of the work of WHO to make this alternative much more affordable, so really contribute to reduce the price. And it's the reason that last year in 2021, for the first time, WHO included in its what we call the essential medicine list for children and adults. They decided, experts decided to include a first list of dental products. And as part of this list, you have some materials that Professor Edward mentioned. So it means that this list, will provide technical guidance to countries to also make such a product and techniques available in countries. And we hope that to be part of this, again, essential list of medicine could also contribute to reduce the price or to ensure that government and Ministry of Health will put in the national essential list of medicament also. So it's really the idea. And in addition, of course, we are working with a network of chief dental officer and WHO corrective centers also to ensure that knowledge, on the use of this alternative would be well known and could be introduced, in dental education, in dental schools for all the new dentists, and to replace now the teaching about dental amalgam. It's also our plan for the next year.
Thank you. It's very interesting, that development of putting the alternative dental products in the WHO list of essential medicines. I think that's a very good initiative, because certainly that listing different pharmaceutical products in such a listing has done a lot to improve the availability of those products around the world, and continues to do so. I mean, it's a living document, is my understanding. Dr. Edward, what do you think of that initiative, and are there any other initiatives to to bring down or to improve the affordability, because that seems to be a key barrier that Benoit has referred to. Do you have any other suggestions, Dr. Edward, and what do you think of this essential medicines listing that Benoit spoke about?
I think the affordability actually varies between different countries and even within a country from place to place. Yeah. So in order to be able to reach out to the really in need people, okay, then the government may have to be selective, okay, and target the populations by subsidizing some of these initiatives. I think that will be one nice way to do it.
And certainly some of the initiatives that you spoke about, such as the regular brushing and so on, is obviously very low cost. And so I guess there's a range of prices there we're talking about. Often we hear about that the longevity and durability of these materials doesn't compare very well to dental amalgam. Could I ask both you, Edward, and Dr. Tammy, what you think about that? Dr. Edward, perhaps you could go first.
Yes, okay. Actually, the alternative materials, have been is developing. They're becoming better and better, all the time. Actually, there are a number of clinical studies, to look at the survival rate. That means that how long they can remain in the teeth, and the survival rate of the glass ionomer cement restorations and the resin composite restorations actually is comparable to the traditional amalgam restorations. Yeah. That means that there's no big differences in terms of survival rate. And also we can expect these alternative materials become better because there are more research and more development on these products.
Dr. Tammy, do you want to add anything there about the longevity and durability of the alternative?
I think we are now like having a lot of randomized clinical trial, like Professor Edward Lowe saying that the longevity of the composite is getting better and better. And glass ionomer cement, they have like the viscosity glass ionomer cement that can be used in the loading areas of the big cavity. So I think, in fact, like the so-called the longevity of the amalgam itself, because amalgam you need to do the cut the teeth more actually. So even though like amalgam itself is stronger, but when you do the preparation, that means you cut the tooth more. So that means in the future, this tooth would be a little bit like weaker instead, or what we call a vicious cycle. That means when you have the small cavity and then you probably have to use amalgam, you have to cut more tooth structure. So this one also like we have to consider this point as well.
Thank you. I'm looking to see if anyone has their hands raised, but I see a couple of questions in the Q&A. Well, one isn't a question really. One is giving a link to a short video of mercury-free dentistry and healthcare initiatives in Nepal. There seems to be a lot of discussion about this phasing out and how long it may take. Benoit, do you have anything to add to that, based on your experience in how these sorts of changes in use of materials, how long it might take? I think that's really at the heart of the question from Sefid about how phasing down, how long would phasing down take?
Yes, thank you for the question. It's not an easy one because as you have seen, in the findings of our consultation, really show them a very quite important gaps among countries and regions. So as you know, of course, a number of countries limited, unfortunately, already phase out the use of dental amalgam. Some others are progressing well in phasing down, and some others just started, to plan and to progress in the implementation of the measures. So it's the reason that part of the conclusion of the consultation, WHO think that it would be important to certainly develop a timeline to ensure that we have certainly a more clear ideas in terms of the time frame, to implement some specific measures. But again, all these decisions, of course, are in the hand of the parties. And I think it will be part of the discussion, in Bali in a few days now. And of course, the national context, the domestic context could be, of course, be considered, because again, certainly some low-income countries and also affected by a huge burden of dental caries should be supported, in moving this agenda, because it means quite a lot of reforms in terms of at dental school levels, but also in terms of in terms of regulation of the import of product, including dental amalgam, but also alternative. So there is a number of reforms or decisions that should be taken at country level to really support the oral health sectors, to ensure that we have a real acceleration, in implementation of this phasing down. Thank you.
Thank you. And I guess we've heard it a lot recently in the COVID pandemic about vaccination, and that we're not all fully vaccinated till everybody is vaccinated. And I guess that's that may be part of your the way that you're looking at things a little bit, Benoit, as well, by phasing down requires, from your point of view, all countries to have moved to different alternatives. Could I ask about, are there any, and this is basically to any of the panelists, are there any advantages, I guess, to the availability of the alternatives? So how will the decline of the availability of the amalgam and the uptake of alternatives help lower income countries? Are there any as the products become more widely available, will they become cheaper, for example? Are there any other advantages, such as the skills that people need to apply them?
So maybe I give my opinion first.
Yeah, sure. Go ahead, please, Edward.
Most of the alternatives that I've mentioned in my presentation actually do not require high technology or highly trained personnel. So for the low-income countries where they may have difficulties in having setting up sophisticated dental clinics and recruiting highly trained dentists to use amalgams for the treatment of tooth decay, then this alternative actually will help them in order to manage the tooth decay situation in the population. And also with these new alternatives, one of the good things about these is that both of them do not need to use powered dental equipment, and so there will be no aerosol generating procedures. And so it's very good, especially in the current situation with the COVID pandemic. And so it actually is safer to provide these alternative treatments, like SDF caries arrest treatments, or to use gas elements as cement restorations. And also, with increasing use of these alternatives, the price will go down. With economy according to the scale of use. So that will help the access of dental care in the less resource rich areas.
Well, that would be a very good thing to see happen. Dr. Chaney, would you like to add anything to this?
I think Professor Low already mentioned all. So I think I may share some experiences in Hong Kong that during the pandemic, we still going for the community care and using the silver diamine fluoride in young children. And what we found that there was no close infection over 2 years. So this something is quite promising that we do not generate the aerosol, and using PPE in phase 2, using a simple and safe technique that can provide at least to stop disease for young children, in particular in the COVID-19.
Yes, it certainly would
Thank
be
you.
an added advantage from what we hear about the aerosol generation and so on. There's a couple of questions in the Q&A about the safety issues associated with the alternative fillings. There's some mention of these silver salts and or silver solution you mentioned, and the fluoride. Do you have anything to add to that? Is there any new findings that are relevant, or any safety studies that are available on these alternatives that we mentioned? Who would like to, Dr. Edward?
Okay, yes, Yeah, the fluoride toothpaste actually has been in use for decades. The concentration of the fluoride in the toothpaste actually is a very safe level. Will not cause any health problems of concern, and also it's very safe to the environment. Because fluoride is a natural occurring element, very common in the environment anyway. So it will not cause additional burden, because the amount of fluoride that's used actually is not high. And the same for the amount of fluoride in the fluoride varnish, or even used in the silver diamine fluoride solution, because the amount that we use is minimal. Actually, for example, we can use 1 drop of the SDF solution, and we can treat the tooth decay in many children already. So the amount of fluoride or the silver ion contribution to environment actually is minimal. Even though it may sound concern when I say it's high concentration, but when we talk about the actual amount, actually it's very small amount. When compared to amalgam, we're talking a big piece, a big bulk of mercury and silver. So this alternative actually is very safe, and actually is good for the environment. And also for the resin composite, actually is also very safe material.
Thank you for that. I think this is an area where obviously there's a lot of more information to share, but it's been very good this afternoon to sort of initiate the dialogue. And as Benoit said, that he certainly would be looking forward to having some more detailed discussions during the week of the conference of the parties. I think with looking at the clock, we only have a couple of more minutes left this afternoon. So I'd like to hand back to Isaac Toda to close the session for us. And if Isaac, you'd like to add any of your views on this issue, on what you've heard this afternoon, that would be very much appreciated. So back to you, Isaac.
Thank you, Leslie, and I apologize for not being able to start the video. There's a technical problem, so so sorry about this. And this was a very enlightening session, as I mentioned at the opening, we very much appreciate the WHO's effort to reach out to the parties and conference parties and other stakeholders, because the Article 16 of the Convention provides that the conference of the parties, in considering the health-related issues, will consult and collaborate with World Health Organization. So we very much rely on the expertise from WHO. The document Benoit mentioned is already distributed as an INF document 26, and we are hoping that to be able to share the briefing note as an additional information document. So we very much look forward to the fruitful discussion, very informed discussion at COP on dental amalgam, and expect the good scientific and technical advice from WHO. Thank you very much to the WHO, the organizer, and the participants. And the last thing to mention is that the last side event in 30 minutes from now is also on dental amalgam. Thank you very much.
Thank you so much, and thank you to our speakers, Dr. Edward, Dr. Benoit, and Tammy, and thanks to everybody for joining us this afternoon. Thank you.
Thank you.
Thanks,
Bye-bye.
everyone.
It's a pleasure.
Yes.
Bye.
Thank you.
Bye.